generous and a little bit embarrassing introduction. Before I start, I'd like to acknowledge the traditional owners of the land in which we gather today and pay my respects, past and present. I've called my talk The Changing Nature of Children's Health Challenges and Opportunities because it's both of those. There are huge challenges that modern child health pose to us, but there are also opportunities. And you'll see at the end of my talk that even though, to my mind, I'll show you some data in a moment, child health has changed so much, policy and funding and our conceptualisation of how to do the right thing for kids lags a long way behind. So I'd like to show you some data about changing paediatric morbidity, indicate there's pressure on tertiary services, both in the hospital. I work at the Children's Hospital in Melbourne, huge pressure on both inpatient beds and ambulatory services, but also, as I go around the country, there's pressure on tertiary services in all hospitals and at a community level. Talk about, briefly, brain development and the life course, because I don't believe you can be exposed to the research about brain development and continue business as usual. I call it startling research. Talk about the social gradient, both in access and outcomes, and that social gradient is getting larger and larger as this first world high-income country prospers. If that's not a national emergency, I don't know what is. Talk about the fragmented service system where funding models and service models lag 20, 30 years behind the data. And then the opportunity, I think, is a brave new world, and that is to focus on prevention, early intervention, to really disrupt our present service system in communities. I don't think that anything short of major disruption is really going to be of service to children and families. Talk about an advocacy role for all of us in trying to promote prevention and get us into this brave new world. And then from my point of view, working at a hospital, I believe that hospitals really should embrace a new mission. So first of all, changing paediatric morbidity. Bob Haggerty was for a short period of time, one of my mentors. And in 1975, which is almost 50 years ago, 25 and 16, over 40 years ago, a group of childhood difficulties that we have termed, quote, the new morbidity is now gaining attention. Many of these difficulties lie beyond the boundaries of traditional medical care. Handling such problems will be important to the future of paediatric practice. And it's interesting to reflect on how well we've done as a service system in handling these problems. Peter Hewson, who was a paediatrician down at Geelong, which is a regional town about an hour's drive from Melbourne, which has a superb football team for those of you that follow football, published this in the Australian Paediatric Journal in 1998. He organised all of the paediatricians in the Barwon region to document the diagnosis of every patient they saw over a 12-month period. And this is 1998, 20 years ago, and you can see that the top two were ADHD disability, intellectual disability, learning disabilities, etc., etc. So there's a few traditional organic conditions that get up there, but that's what we're hearing again and again from those paediatricians practicing the community. The majority of kids they see have developmental and behavioural and psychosocial issues. And this is Harriet Hiscock's data from the Australian Paediatric Research Network. The top 10 diagnoses for paediatricians who are part of this network, you can see that asthma and allergy sort of sneaks in there towards the end. This is the new morbidity personified in Australia, and review diagnoses the same thing. So paediatricians are seeing kids with these developmental and behavioural and psychosocial problems. And the Australian Early Developmental Census, which used to be the ADI, nationwide, 1 in 5 children, 1 in 5 arrives in school developmentally vulnerable or at risk. And we heard John Bolton before, and I heard him yesterday to say that in rural Kimberley's outside Derby, I think John, you said 80% and 60% rather than 22% and 9.7, which is, to my mind, is a national emergency to continue. This is the third wave of data, and how can it be we've come to accept that 1 in 5 kids arrives at school in trouble and continue business as usual? There are geographic differences in AEDC results. You can see as we move from major cities down to remote and very remote, these results get worse. So there's no question in Australia that if you live outside the major population centres, children have a significantly increased chance of arriving at school vulnerable or at risk in their development. There's pressure on tertiary services. I'm going to give you some data from my hospital, the Children's Hospital. These are Gary Freed's data. You can see a huge increase over the years in presentations to the emergency department, and there are all sorts of reasons for that, but they end up in a tertiary care hospital. Outpatient attendances increase. Inpatient admission is starting to level out a little bit because we're putting a lot of effort into keeping children outside hospital. And this is Charlie Janeway, who said this many, many years ago. Most paediatric admissions represent a failure of the healthcare system. Let me say that again because I think it's extraordinarily powerful. Most paediatric admissions represent a failure of the healthcare system. And the corollary of that is what went wrong in the community that this child needed to end up in tertiary care. And the corollary of that for us, for the work that we do in the centre, is how can we be working with families and the universal service system, both health and non-health, to prevent these problems from occurring, and if they do occur, for them to be managed appropriately in community settings. So why are we having this increased demand? Well, a number of reasons, and this relates to Victoria in particular, but I think it's perhaps relevant to other urban centres as well. Rapid population increases. So in growth areas around Melbourne, there's just huge explosions of population. So look at Wyndham, 80 births a week. That's 11 or 12 births every single day of the week. 365 days of the year. So that represents a new kindergarten each week and a new primary school every couple of months. And it's no surprise that the infrastructure lags behind, that the first thing, and this is a classic siloed government, that one arm of government says, we've got an exploding population, we need cheap housing, they open up broad acres, developers come in, build houses, and sometimes if we're lucky there'll be provision for a school or provision for a kindergarten, but there's nothing about the sort of things we know are very important for families. A common meeting place, transport hub, shopping, etc., etc. And these are Gary Freed's data. You can see that we have an ageing population, which is no surprise. We read about it all of the time, and some of us are responsible for that. You can see a logarithmic increase in the age of the population. Kids' slight increase. And if we look at GP visits, these are Gary's data again, you can see that GPs spend more and more of their time with older patients. And you can see the number of visits with kids is mainly static. And then this is an interesting data, the proportion of all visits that last longer than 40 minutes. And you can see again, significant increase in aged care. So does this crowd out the time they spend with children? So the implications are, we wonder whether, because GPs are seeing fewer kids, they're not as comfortable, the level of confidence and competence decreases, therefore they don't spend as much time taking developmental histories and doing screening tests and so on, which means they bail out sooner, they refer to paediatricians and tertiary centres, and often they're uninformed referrals because the GPs don't have time to sit down and really work out what's going on. This is the brain development research that I was mentioning, that we know that children's development is the end result of this transaction between biology and experience, this infinite dance between the genes that we're born with and environmental experiences. And we can't do much to change biology, despite extraordinarily exciting advances in genetics. We still can't do much for populations of children to affect their genes. Where we can intervene is at the level of the environment. We've known for decades exactly the sort of things that a young child needs to thrive and prosper, and conversely, those things that pose a risk to development. And this is what the neuroscience of brain development tells us, that the brain architecture and skills are built in a very, very rigid, hierarchical, bottom-up sequence, so that the genes provide the roadmap or the manual, but the way development unfolds is very dependent on the quality of environmental input that the child, the infant, receives. And those foundations are important because higher level skills and competencies are built on those foundations. And the analogy we use is like the foundations of a house. If the foundations are solid, everything that follows is solid as well. But if the foundations are substandard, because we use cheap cement or a shady contractor, then everything that follows is potentially at risk. And so it is with young children. You can go back later on and try and fix the foundations, but it's expensive and difficult, and it'll never be quite as good as if we would have got right the first time. And what happens over time is the plasticity of the brain decreases, and it gets harder and harder to change. So any of us in this room today that have tried to pick up a skill as an adult, whether it's a language or a sport, we can do it, of course, because we never stop learning. But it's much harder in adult life because the plasticity of the brain has decreased significantly. So the research is very clear that biologically and economically, it makes much more sense to get it right the first time than to go back later on and try and fix things up. And we know that disadvantaged environments and dysfunctional parenting in those early years, children that don't have the quality of the environmental input that we know is important for development, get into trouble fairly early on. There are problems in children. All of us working in the child sector see increasing rates of children with these sorts of problems. But what's important from a policy point of view is that there's now evidence from the life course literature that gets more and more robust by the month, that many conditions we see in adult life have their origins in pathways that begin in the first 5 years of life. And the major risk to children is poverty and its associations. That children that grow up in a disadvantaged environment have a significantly increased chance of an environment that's stressful for them, whether it's dysfunctional parenting or whether it's extreme poverty and trying to get food on the table, whether it's single parents coping with a whole lot of kids, whatever it happens to be. And the mechanisms for stress are increasingly being understood. So chronic stress, a young child exposed to significantly prolonged periods of stress, leads to significantly higher stress hormones, and that really resets all the body's stabilization systems. It resets the physiology of immunology, of cardiovascular, etc., etc. And these are kids that are in what we call double jeopardy. These are children whose parents would really benefit from the sort of support we know can make a difference to them, yet are the least likely to access them. These are young children who would get the most out of going to high-quality childcare, high-quality early learning, and we know from Australian data they're the least likely to go. These are children who really need to go to good schools, but go to schools that are disadvantaged and often don't have the resources. And these are Australian data. You can see the social gradient starts before birth. You can see the left-hand side, there are significant differences in women who smoked between Indigenous, non-Indigenous, rural and urban, and disadvantaged and advantaged. And that the consequences then are the same gradient for low birth weight. And this becomes even greater as these developmental competencies emerge. So for many years, this is the slide that I and my colleagues use. These are American data from Hart and Risley's longitudinal study. You can see that children start off at birth with round about the same sort of potential. But look at these differences in vocabulary by the time these kids get to 3. And remember what I said before, the research tells us the plasticity of the brain decreases over time. So the trajectory for many of these kids is very, very hard to change. And these are Australian data, so we don't have to use American data anymore. These are data from the longitudinal study of Australian children. You can see for social emotional difficulties, for communication, for vocab, for emergent literacy, we can see differences between advantaged and disadvantaged children emerge from 2 or 3 years of age. And finally, the AEDC, you can see this social gradient. So this confirms what we've known for a long period of time. And it's not just confined to development. All of the conditions have a social gradient. These data are from Melissa Wake's studies on obesity and BMI score. You can see again a significant social gradient. If you come from a disadvantaged environment, you are at risk from before birth. So as I said before, early adversity, any sort of adversity operating in that child's environment has the potential to cause chronic stress and lead to increase in stress hormones, and then significantly interfere with optimal brain development. I mean, this has been called toxic stress by our colleagues overseas, and we see this in extreme situations like child abuse, family violence, dysfunctional parenting because of substance abuse or mental health problems, maternal depression, etc., etc. And that affects the body's biological systems and makes the child more vulnerable to problems right through life. And the late Clyde Hertzman used to call this the biologic embedding of environmental events, that after a generation or two you're starting to see differences in the genetic material. And these are some of the adult problems that we see in our society, that if this was an adult conference and I was an adult policymaker, I'd put these up and say these are problems that we as a society are wrestling with. And look at the diversity of these sorts of conditions. Not just your traditional psychosocial sorts of issues, but obesity, heart disease, some cancers now. So for many of these conditions in adult life, the research has become clearer that the antecedents or the early pathways begin before children get to school. And we have a fragmented service system. This is true whether we're in a big city or in a rural area. In all but the most remote communities, there's an existing service system. It's not as if there's nothing out there, but you can see different colours, different shapes, different sizes. As a colleague of mine from the US says, you need a university degree to negotiate your way around the service system. And there are lots of barriers. Just because you have a service system doesn't mean that people use them. And you've all heard of the inverse care law. Those that are the most likely to benefit from the service system are those that are least likely to use them. So there are structural barriers, there are family level barriers. None of these will be new to you. There are relationship or interpersonal or cultural barriers. There are lots of reasons why people don't use services. And this is an actual child's journey. This is the Blue Sky project that we did with the Victorian government in Melbourne, which is a rapidly growing area. Very complex slide because a child's journey through the service system is extraordinarily complex, trying to negotiate their way between health and education and welfare. There are barriers everywhere. New histories, new reports, waiting lists, referrals. Very rarely are feedback loops implemented. So at a minimum, we should be starting to link up those services. So my view is that every single service provider, whether it's an early learning centre or a maternal and child health nurse or a GP, should be aware of every single support service in their community. So they should be linked in some way. Referral pathways should be very easily negotiated. But we should go more than that. We really should have a virtual one-stop shop, whether we call it a child and family centre or a community hub. It really doesn't matter what it is, but it's a virtual one-stop shop. So everywhere that a child and family make contact with the service system, you've come to the right place. If I can't help you, I'll take responsibility for making sure that I hand you over or refer you to somebody who can. And the example that I always use is of persistent sleep problems in a toddler. We know that those of us that have had families, how hard that is. But for vulnerable families, a child that wakes continually 2, 3, 4 years of age can really just tip them over the top and creates a very stressful environment. So we wouldn't expect a childcare professional to know what to do about sleep because they don't have a clinical training. But in an ideal world, we might expect that professional to notice this mother is looking really tired and stressed, and to raise the question. You're looking really tired these days, Mrs. Smith. Is everything okay? Oh no, my toddler's up all night and he gets into our bed and my husband has to go and sleep on the couch and he's cranky in the morning and he's stressed and he's worried that he might lose his job. Do you know that there's a nurse, GP, psychologist, paediatrician in the community? They're interested in sleep problems. They can help you. Would you like me to make an appointment for you? What about next Thursday at 10 o'clock? Does that suit? Okay, terrific. They're expecting you. Here's how you get there. You can park around the back or you can catch this tram or bus. When that mother comes to pick up the child at the end of the day, did you keep that appointment this morning? Oh, you couldn't keep it? That's okay. We'll make another one, shall we? So that's every professional in the community not knowing what's wrong, but knowing there's something not quite right, and taking responsibility for referring to somebody in that community who can sort things out. That's an integrated service system. And then this brave new world, a focus on prevention, reorganisation, advocacy, etc. This is a terrific quote that I'm going to read out to you. A vision of prevention. As our medical services are organised at present, preventive medicine is regulated to the role of minor importance. Medical knowledge of the prevention of disease is far in advance of our present practical application of this knowledge. It is to be hoped that a greater effort will be directed towards the prevention of disease. Terrific quote, written in 1941 by Howard Williams, who was a visionary leader at the Children's Hospital in Melbourne. So that's 70 years later. I can put up this slide now. We've gained very little traction because prevention is such a hard sell. But somehow, as a health professional community, we need to start changing our focus from reacting to problems. So people like myself and many of my colleagues sit in an office at the hospital, many of you do the same in the community, waiting for patients to be referred. And that's fine. I'm sure we do a great job one at a time. But we really do need to move our thinking towards populations of children and prevention. And the earlier we start to do that, the better. Because if we start intervention early, at the very first signs that things are going off the rails, then the cost of the intervention is low and the effectiveness is high. The longer we wait, the cost goes up and the effectiveness goes down. Trajectories get harder and harder to change. So, for example, we're expecting schools to compensate for what's happened in the first 5 years of life before the kids get to schools. And it's an impossible task, because by 5, those trajectories are harder and harder to change. So generally, public policy waits until we get to the right hand of that graph, and then governments throw money at issues. So the next time you see any government minister challenged about any sort of problem, make note, I promise you 100% of the time they'll respond in dollar terms. 10 million, 20 million, 5 million, 30 million more than the last government, but it's at a time when at a population level, the evidence you can fix these problems simply isn't there. These are political solutions, they're not scientific solutions. So all the evidence tells us, screams at us that we should be intervening early in this cycle. So in Victoria, I'm told it costs $200,000 a year to keep one person in prison. And I suspect that I could go to any prison in Victoria and write a generic life course that would fit 80% of the people in there. And you all know what that story is. So much cheaper at the age of 1 year or 2 year or 3 year or 4 years to intervene then. And when governments say we can't afford it, my response is you either pay now or pay later. And then for hospitals, there needs to be a broadening of the mission, that it's not just about looking after sick children or offering tertiary services in ambulatory settings. We need to start thinking about ourselves as a system of care, not just a collection of beds, and push our mission beyond just the treatment of the disease towards education, advocacy, prevention, and so on. And that means we have to develop very strong and trusting links with our partners, other agencies in the community. And just a couple of ads. This is a parenting website that that we co-manage with the Parenting Research Centre in Victoria, Raising Children. It's funded by your government, your taxes pay for it. And this is like a one-stop shop for peer-reviewed information about child health, about parenting, autism, disability, etc., etc. And two of my favourite features are My Neighbourhood. So if you type in your postcode, you get a Google map of your neighbourhood, and superimposed on that are childcare centres, hospitals, pharmacies, etc. And my actual favourite is something called Baby Karaoke, because when we interviewed parents asking what sort of information they'd like and how they'd like to receive it, lots of parents said to us they like to sing to their kids, they know that it's important to engage them like that, but they can't remember the words or they're self-conscious about the tune. So Baby Karaoke has a pull-down menu of about 20 common nursery rhymes with prominent Australian singers who have given their time pro bono. And then a lot of translation vehicles coming out of the centre. So if you haven't subscribed to our website, I would encourage you to do so. And Carol talked about early literacy. This is a early literacy program where we're encouraging parents to read to young children from a very early age. And we're doing that through providing information and training for professionals. So in summary, there's been huge changes in childhood morbidity, startling increases, unmanageable increases in numbers of children with developmental, behavioural and psychosocial problems. Disadvantage and equity are major contributors to that, and we have a fragmented service system. So this calls for totally new approaches to services. You know, I don't think anything short of disrupting the present system, a paradigm shift in our thinking, is really going to cut it. An emphasis on prevention and early intervention. And the trouble with prevention is that it's such a hard policy sell because it's invisible. There are no plaques on buildings, there are very few photo opportunities, there are no announcements to make. Building capacity in families and building capacity in communities is really the only game in town, and yet it's such a hard sell to policymakers. And then finally, an advocacy role. I think it behoves all of us sitting in this room to become advocates. And the reason is, this is Sven Silber's slide, if we did nothing, we know that all children would fall away in terms of their development because of biological and especially environmental risk. This is what we really aim for every single child to fulfil his or her potential. And it's not as if we don't do anything. There's a huge investment at a local, state, federal, philanthropic level on services. But current practice is where that red line is. But we know enough theoretically now to lift children from that red line to the green line, and that's the opportunity we have as a society, as a community, etc. And the language I use now is we need a snowy mountain scheme for children and families. We need that sort of bold thinking that somebody after the war had this crazy idea of damming the Snowy River and all its tributaries. That's the bold visionary thinking that we need to make a difference to children. Thank you very much.